Hello.
Hi there.
Dr. Nitin, hello.
Yeah, I can hear you.
Dr. K.K. Krawal will be there around 6:45.
6:45. That's fine. Yeah, I can hear you.
Dr. K.K. Krawal will be there around 6:45.
6:45. That's fine. Yeah, I can hear you.
Dr. K.K.
Namaskar, Nitinji. If you are there, we'll start 0 hour.
Dr. Agarwal, I'm there. How are you?
Fine. Let's start at 0 hour. 0 hour means like Parliament. And officially, we will start in the next maybe 7 minutes. But we can have a 0 hour with that. So when did you go to America? And why did you go to America?
I've been there since now 2001. I'm from Maulana Azad, and after finishing my MBBS, I did my DNB in medicine, and then after that I went.
So in Maulana Azad, you joined in which batch?
Maulana Azad, I'm 1993. Joined in 1993, passed out 1998.
Okay, and then you went for, after MBBS, you did your MD from?
I did my DNB in medicine from Gangaram Hospital.
Good. With your dad?
With my father. Yes. And then I came and did my medicine residency at in Washington, in Maryland. And then I did my neurology at New York at St. Vincent's Hospital, and then my neurophysiology fellowship at Cornell.
So I used to work with your dad in Mulchan Hospital.
He told me, he said he knows you since the day of Mulchan. Yes. I remember driving him to Mulchan many times.
So and, at that time, I was with Dr. K.L. Chopra with the cardiology. Yes. Dr. K.L. Chopra is the father of Deepak Chopra.
Yes, yes.
And Sanjeev Chopra he was in Harvard. Deepak was, now he's from endocrinology shifted to Ayurveda. And his father was my boss in Mulchan.
Okay. Yeah, Dr. Chopra had he did a big Zoom on when this pandemic was going on. He did a big internet meditation and session, and the whole internet apparently crashed because so many people logged on from all over the world.
Good, that's what he is. That's what he is.
Yeah.
With that. So, what are your hobbies?
I like to drum. I'm a drummer. And I've been boxing for many years, and that's how I'm the chief medical officer for the Boxing Commission. So I cover all the professional boxing, UFC, MMA fights here. So those are my two hobbies.
I'm currently the president of Confederation of Medical Association of Asia and Oceania, and which is a part of World Medical Association. And somehow or other, there is a movement going on amongst the medical profession that medical professions should not support boxing.
That's right. Actually, no medical association supports boxing. The American Academy of Neurology, American Academy of Pediatrics, British Medical Association. So I faced a lot of heat for that.
One simple concussion can be dangerous.
Very, very true. So I head the Concussion and Brain Injury Center here at Cornell. So that was the reason I love boxing. I love traumatic brain injury, and I wanted to mix my loves of both the loves. That's why I started making sure that I do the right thing and protect these fighters.
So what is there in boxing which can injure a person? Is it like intentional? Is it unintentional? Or this is your part of the game that you have to hit him on the head?
Yeah, the professional boxing, every punch thrown at the head is thrown with the idea to cause a knockout. So, you'll see a lot of concussions. You'll see, heavens forbid, sometimes acute traumatic brain injury. Boxers have died in the ring. So we have a lot of protocols to try to make everything safe, which people, how do we assess them before the fight, manage their brain health, tracking them over the years. When do we tell them to stop fighting? During the fight itself, and then after the fight is over, which ones go to the ER for a CAT scan. There's a level 1 trauma center, which is on backup every fight. So, there's a whole sort of a thing, how we make sure that everything runs fine.
So let's analyze your name. We have 3 minutes before we start. Let's analyze your name. Na, I, ta, I, na means what? Na.
I know that my name means Lord, is another name of Lord Vishnu.
No, but your name is Na, I, ta, I, na.
Right.
Na, I, ta, I, na. So what is Na? So you have 2 Na and 1 Ta.
Right.
What is Ta?
I don't know. I never looked at my name in that way. I always think of it as like palindromic. Dad and mom, my sister's name Nitika.
When do we use ta? Ta is tat sat.
That's
Shri
that.
Narayanatu. So tat is the name of the god.
Oh, okay.
So the word ta is representative of Brahma, Vishnu, and Mahesh. So
Oh,
ta
thank you.
basically represents your consciousness, your collective consciousness. So whenever we use the word ta, is collective consciousness. E, E, you have two E. E. So whenever
Right.
we use a vowel, we use a vowel with three things. A, we expand. E, we contract. U, we totally contract.
Mm-hmm.
It is in between A and U. Okay. 2E becomes A.
Okay.
When do you speak A? So whenever you have pain.
Whenever you're pain. Okay.
So whenever you have pain, you will produce interleukin 2, which is a
Right.
painkiller.
Mm-hmm.
And which is, so therefore all vowels will produce painkiller. Okay. Then ma and na are nasal consonants. Okay. They are produced when you weep.
Mm-hmm.
When you weep, you produce na. And
Got
when
it.
you produce na, you produce delta activity in the EEG, which causes tranquility of mind.
That's very nice. I like it.
Okay. So na will give you tranquility.
Okay.
Then 2 na will become ma.
Okay.
2E will become O. So 2E and 2 na becomes Om. And ta gives you the feeling of that. So you are a name of a god with the power of the word Om. That is what Nitin.
Oh, thank you so much.
Thank you.
I Googled this many times and never got it.
You will not. You will have to listen to me for that. Kindly share your screen and we
Okay.
start.
And I have a small presentation after that on the COVID thing.
Yes. Okay, we'll do that also.
Okay, so let me share screen.
So hello everybody. Greetings from IGCP Group and MedTalks and Heartcare Foundation of India. I am Dr. K.K. Agarwal, President, Confederation of Medical Association of Asia and Oceania. And I'm also currently the President of Heartcare Foundation of India, past President of Indian Medical Association and editor of IGCP Group. I present to you Dr. Nitin K. Sethi. He's son of my boss, my mentor, my guru, a great neurologist in Delhi who is also a Padma awardee. And Nitin is currently the Associate Professor of Neurology at New York Presbyterian Hospital and Weill Cornell Medical Center. He is a Director and Chief Coordinator of Brain Care Foundation. He is a diplomat of National Board of Internal Medicine. He did his DNB from India. He is a diplomat American Board of Psychiatry and Neurology. He is a diplomat American Board of Clinical Neurophysiology. He is an American Board of Psychiatry and Neurology. And he's an American board of with added competency in sleep medicine, in epilepsy, and in epilepsy monitoring, intraoperative monitoring, blah, blah, blah. And he is also diplomat American College of Sports Medicine. He's very much in fond of boxing. He manages the box first aid center in US. And we are going to interact with him basically on management of refractory status epilepticus. And we will talk about the role of newer anti-epileptic drugs. And he also has a large number of experience in managing COVID patients, and he wants to share his experience in the end about the COVID patient. Ladies and gentlemen, and my dear colleague, I present to you Dr. Nitin K. Sethi.
Thank you, Dr. Agarwal. Thank you for this kind invitation. And my father remembers you fondly too.
Thank you.
So the topic is management of refractory status epilepticus and what's the role of the newer anticonvulsant
Can you
drugs.
make it a full screen because
Is that now full screen?
No. Anyway, go ahead.
Let me just
Ritu, try if you can do it. Go ahead, Nathan.
Right. So, as we know that when you talk about refractory status epilepticus, the definition of status epilepticus has changed over the years, but now the definition stands at that if you have 5 minutes or more of continuous seizure activity, that by definition is status epilepticus. A practical way of looking at that is if a patient comes to you and the patient is actually having a seizure right then and there, if you're in the hospital setting, the patient is seizing, that is treated usually as a status epilepticus. Now, a few more terms came about over the years. There's a term called refractory status epilepticus, and then now there's a term called super refractory status epilepticus. Refractory status epilepticus is that when the patient comes to you with status epilepticus, you give the first line anticonvulsant, which is usually a benzodiazepine, which is administered IV, and you follow that with a second anticonvulsant, a frontline drug, most usually is Dilantin or Phenytoin. And that's basically the term when it's used for refractory status epilepticus. If the seizures persist after that, that's refractory status epilepticus. Now, super refractory status epilepticus occurs when you've gone further down that protocol. So you have given the patient IV benzodiazepine, the seizures are still continuing. You gave the patient a frontline anticonvulsant like Phenytoin or phenobarbital, the seizures are continuing. So now you've gone and given the patient IV anesthetic. And now the patient is in the ICU setting on IV anesthetics. And whenever you try to lower the IV anesthetics, the seizures come back. So it's very difficult to wean these patients off IV pentobarbital or propofol. And that term is nowadays called as super refractory status epilepticus. As the slide shows, the incidence of status epilepticus ranges from 5 to 40 per 100,000 population. There's no real significant difference in males and females. You'll see status epilepticus in developing countries, developed countries. Refractory status epilepticus will occur in about anywhere between 25 to 50% of status epilepticus cases. They'll go into refractory status epilepticus, and then some of them will go into super refractory status epilepticus. Now, whenever we talk about any of these etiologies, we've got to think about what is the underlying etiology of status epilepticus. Why is the patient having status epilepticus? And as you can see on the slide, there are many different etiologies for status epilepticus. The most common cause of status epilepticus is usually a patient who's epilepsy patient who has stopped taking his anticonvulsants. Either they are non-compliant with the medication, or they're taking it, but they're not taking it in the right dose, so they are subtherapeutic levels. So that's the most common cause why these patients come in with status epilepticus and then become refractory status epilepticus. But there can be other etiologies of status epilepticus. Strokes, CNS infections, patients with dementias will go into status epilepticus, cortical dysplasias, head trauma. You'll have toxic causes like excessive alcohol, intoxication with some drugs. And so there's a whole sort of whole category of what etiology of status epilepticus. And usually the best thing is the thing to remember is that the most common cause will be a patient who has epilepsy and for some reason has been non-compliant with his or her medications. Now, we all know the management of status epilepticus is very challenging. One big part of the management is you want to try to establish what's the etiology of the status epilepticus, what is leading to the status epilepticus, and we discussed the causes in the previous slide. But in many cases, you'll find that you are not able to establish a cause. So many cases of refractory, super refractory status epilepticus, you'll not be able to find a cause why the patient is having this. And so there's a new term called new onset refractory status epilepticus. And so usually the treatment initially is emergency treatment is control the status epilepticus. And as we know, the main drugs which are used in this are the benzodiazepines, and then we'll have the frontline anticonvulsants. And benzodiazepines are usually helping rapid control of the status epilepticus. And then as we go further and further down the protocol, I'll describe it later, you go into intravenous anesthetic agents. So talking about benzodiazepines, they are the frontline drugs used to control status epilepticus. As we know, they work on the GABA receptor in the brain, GABA type A receptors. One very big advantage of benzodiazepine is they're available in multiple formulations. So you have an oral tablet. You can have an oral tablet of diazepam or lorazepam. You can have, they come in intravenous form, intramuscular form. Nowadays, we have intranasal forms of midazolam. Diazepam can be given per rectum. So that's a very big advantage. You can really get it into the patient in many different forms. And as we know, commonly used benzodiazepines include diazepam, which is available in per rectal form in children. So per rectal diazepam is used to control status epilepticus or breakthrough seizures in small children. We have lorazepam, and then we have midazolam. A very important point to remember for any control of status epilepticus is these medicines will work better if you use them early and close to seizure onset. The longer the status epilepticus continues, the harder it is to control the status. The other important point to remember is when you give these medications in status epilepticus, you want to give them in the right dose, what is called the load-in dose, and over the right period of time. And there's a graph in the next slide, and I'll explain this again. But lorazepam, it's important to remember that the load-in dose is 0.1 milligram per kg of body weight to be given at about 2 milligrams per minute. So let's assume, while it says a maximum 8 milligrams, let's assume the patient is, about, let's say it's 100 kgs patient. That means we want to give a total dose about 10 milligrams or 8 milligrams. You want to give it over 2 milligrams per minute. So in about 4 minutes, you want to get the lorazepam inside, because like I said, the earlier you get the lorazepam inside, the better it will be to control the status. After lorazepam, usually you follow that with a second frontline anticonvulsant, and that will be usually dilantin, that's phenytoin. And remember, the loading dose of phenytoin, about 18 to 20 milligrams per kg of body weight at rate about 50 milligrams per minute. Now, why is this important? A lot of times, no matter what the weight of patient, we'll give just 1 gram of dilantin. No, you want to give it based on weight, and you want to give it at the right rate of infusion also. Now, we know that phosphonate is also available in some hospitals. It's more expensive. But the advantage of phosphonate is it can be given 3 times as faster. So it can be given at 150 milligrams per minute. So let's assume it's going to take you 20 minutes to get a gram of dilantin into the patient. Here, you'll be able to get it much, much quicker. Now, if the seizure is still persisting, you follow that with a second dose of phenytoin. That'll be half of the loading dose. So if you gave 10 milligrams initially, you give 5 milligrams per kg of body weight. And then as the protocol goes further, we have the option of going into phenobarbital and then the IV anesthetics. So this is one of the status epilepticus protocol. Again, important points to take away. Lorazepam loading dose, 0.1 milligram per kg of body weight at a rate of 2 milligrams per minute. So if you have calculated, I'm going to give 8 milligrams to my patient, you want to get that within about 3 or 4 minutes inside the patient. Very, very rapidly, you want to get it inside, because the sooner you get it inside, the better it is. Phenytoin, 20 milligrams per kg. So let's assume the patient is 100 kgs. That obviously is not going to be 1 gram. It's going to be higher than that. So calculate the amount of phenytoin you want to give. And the rate, again, is 50 milligrams per minute. So if you are going to get 1 gram inside, that's 1,000 milligrams, you are looking at getting that inside also pretty rapidly. 10 to 15 minutes, you're getting the phenytoin inside. Now, phosphonate, like I said, the loading dose is the same, but the advantage is if it's available to you, you can give it even faster at the rate of 150 milligrams per minute. Now, if the seizures are still continuing, the patient is still having seizures, you can do a second loading dose of phenytoin, but you use half the initial dose. So if you use 10 milligrams per kg, now you're going to use 5 milligrams per kg of body weight. Now, after that, as you see in the slide, the protocols vary. There will be some centers where they'll say, now we'll give phenobarbital. And the phenobarbital loading dose, as you can see, it's the same as the dilantin loading dose, 20 milligrams per kg of body weight at the same rate, 50 milligrams per minute. Some centers, on the other hand, after phenytoin has stopped, if phenytoin is not working or the patient is still having seizures, they'll directly go to IV anesthetics with either using midazolam or propofol. So again, emphasizing the management of now refractory status epilepticus. Now you have reached the stage where you have given the benzodiazepine, you have given the dilantin, maybe you have used phenobarbital, and now you're going on to IV anesthetics. Now, 2 points to remember. As soon as you're at this stage, you have to have anesthesia there because you're going to be intubating the patient because the patient is not going to be able to maintain his or her airway. So the patient is intubated. Now you have 3 different drugs which you can use depending upon what you have at your center. You can use midazolam, you can use propofol, or you can use pentobarbital. Another point to remember is by this time, once you start giving these medications, what will happen is the patient might visibly stop seizing. So he's not shaking in front of you, but the brain inside might still be seizing. So you usually should have some EEG guidance. If you have electrodes on your head, and in some centers where they have continuous EEG, so you put the patient on a continuous EEG monitor, and now you're loading the midazolam or the propofol or pentobarbital. And as you see in the slide, they use terms called burst suppression. That means basically you keep increasing the dose of these medications till on the EEG, the seizures completely stop. So on the EEG, you see no more misfiring of the brain waves. That's kind of a simple way of what is called burst suppression. So you need 2 things by this point in time. You need the patient to be intubated. So you're already saying that I'm going to need an ICU bed for this patient now. And secondly, you need some EEG guidance as you start using the IV anesthetic drugs. Now, you may say, why does a patient go into refractory status epilepticus or super refractory status epilepticus? Why doesn't the patient not stop after you give the patient diazepam or lorazepam? Well, there are certain reasons for drug resistance. The 2 main reasons are that what has been shown is that there's an internalization of the GABA receptors. You remember I told you lorazepam, diazepam, they work on GABA receptors in the brain. Now the receptor itself gets internalized, it goes inside. So there's no receptor there, and that's why the thinking is these medicines stop acting. There's also an upregulation of this multi-drug resistant protein. And then you're having some neuronal death occurring. There are some excitotoxic mediators being released like NMDA. And these 3 or 4 etiologies are thought to be the reason why a patient stops responding to a benzodiazepine or stops responding to dilantin and is now becoming refractory, super refractory status epilepticus. Now, coming back to status epilepticus management, we know that most of the centers will have dilantin. Some of them will have phosphanatoin, will have phenobarbital. The other agents which can be given IV, valproic acid is thought to be very good as a drug to stop status. Now most of the centers have levetiracetam, and the medication which we are going to talk a little bit about, lacosamide. Lacosamide can also be given IV. So when you look at how many drugs you have available IV to treat status epilepticus, you'll have phenytoin, you'll have valproic acid, you'll have levetiracetam, and you'll have lacosamide and phenobarbital. As happens, the drug is chosen based on your experience, how comfortable you are. If you say, I'm most comfortable using dilantin, then you use dilantin. If you're comfortable using valproic acid or levetiracetam or lacosamide, you can use these drugs. And also, obviously, whether the drug is available to you in the hospital or not. Now, when you talk about newer AEDs for refractory status epilepticus, if you look at the bunch of drugs which are there, and we'll discuss them, I'll just show you this slide. Brevactracetam is a drug which came out recently. Think about it as a newer generation of levetiracetam, but there's limited evidence as of now for use in status epilepticus. So you can certainly use levetiracetam for status epilepticus. Brevactracetam, we have very limited evidence, though brevactracetam is present IV. Now, cannabis or cannabinoid is being used, but we don't have really much management for much recommendation for status epilepticus. Clobazam, very good drug. It does work very well for seizures. The problem we have is it's not in IV formulation. So you cannot give clobazam IV. Same thing with other drugs like eslicarbazepine, perampanel, zonisamide. Some of these drugs are old, some of them are new. The problem which is there, most common, is that there's no IV formulation of these medication. So we come to lacosamide. And lacosamide has a couple of advantages. If you look at the slide in the second point, lacosamide basically acts by inactivation of the voltage-gated sodium channel. So it works on sodium channels. Look at the bioavailability, it's 100%. Half-life is around 13 hours. But most important, availability, the formulations, it's available as an oral medication. It's available as an IV, it's suspension. So it's certainly a very good drug which is there for emergency control of seizures. Other medications which are there, even like zonisamide, a good anticonvulsant with a very long half-life, we don't have it in the IV formulation. So lacosamide, I'd like to present a few points which will help you. It's available both as oral and parenteral. For status epilepticus, the dose which is given ranges from anywhere between 100 milligrams to 400 milligrams. Half-life is around 13 hours. It's renal metabolized, it's excreted unchanged in the urine. So the only thing you have to really worry about is if somebody has end-stage renal disease, then you might need to reduce the dose. It's otherwise generally very well tolerated. And there are now multiple studies which have been done, case reports which have been done, which have shown that this medication works very well. I'll show you a few of them. As you can see, it's been tried in both patients with convulsive status epilepticus, non-convulsive status epilepticus, focal status epilepticus, and seems to respond well in all those three different types of settings. It's been used in children, it's used in adults, seems to respond well. I'd like to kind of one main study which was done was a systematic review of lacosamide in status epilepticus, and it was found that the efficacy was comparable in both non-convulsive and convulsive status epilepticus. It's even better in focal motor status epilepticus. Main adverse events you worry about, lacosamide can cause some dizziness, some abnormal vision, some diplopia, ataxia. The strength of this medication, there's a very little drug-drug interaction. You can use it IV and you can give it rapidly inside. Now, people will say that they worry about the cardiac side effects of this medication. Yes, there is a dose-dependent prolongation of PR interval, but even patients who have AV block, they have not experienced any clinically significant side effects when you give it to them. And there certainly has been no instance of second or third degree AV block. So you can consider cardiac monitoring when you use it with other PR prolonging drugs like carbamazepine or lamotrigine, but otherwise it actually has a good cardiac tolerability. And the only other thing I said, you need to adjust the dose when you're thinking of when you have a patient with severe renal impairment or end-stage renal disease. So summarizing this topic, I kind of went over the terms of refractory status epilepticus. So refractory status epilepticus means when a patient continues to have seizure despite administering the first-line anticonvulsant, which is a benzodiazepine, and one second-line medication like IV anti-epileptic drug like Dilantin. Now, at this point in time, you have a couple of options. You might say, I'll straight away go to IV anesthetic. You might say, no, hold on. Instead, I gave Dilantin, let me give a second anticonvulsant like levetiracetam, or let me give IV lacosamide and see what happens. So the IV formulation of lacosamide you can use as right after you use your benzodiazepine, or you can use it once you have used your benzodiazepine, you have used Dilantin, now you follow that up with IV lacosamide. Benzodiazepine remain the first-line management. They are short-acting, quick-acting. They are followed by a longer-acting medication like phenytoin, phosphonate, phenobarbital. I mentioned levetiracetam, valproic acid, and now you also have lacosamide as an IV formulation. Now, once patients are not responding to that also, unfortunately, then they are going into refractory status epilepticus, and then you have to go on to the IV anesthetic medication like midazolam, propofol, or pentobarbital. Remember, by this time, they are intubated, they've lost the airway. You need an ICU bed to manage them. You need some EEG guidance to know exactly what you're doing. And for some reason, when you try to take them off the medication, if they again start going back into status epilepticus, then that entity is called super refractory status epilepticus. So summarizing, lacosamide is a relatively new anticonvulsant, but it has proven efficacy in the management of refractory status epilepticus. It has an IV formulation. The IV dose ranges from anywhere between 100 to 400 milligrams, well tolerated, very few drug-drug interaction. You worry about the cardiac side effects and the PR prolongation, but actually when you do studies, you find that patients tolerate it pretty well. No instance of second or third degree AV block. And like I said, quick to administer and usually works quite well. Thank you.
Thank you, Nitin. I'll try to summarize by asking you 5 different questions. My first question is, what is about this new drug public should know? Lacosamide, what public should know? What is the public education?
Dr. Agarwal, the main thing which people should know is that, one, it's available in an IV formulation, so you can use it IV. So you can use it in the ICU setting, you can use it in the inpatient hospital setting, you can use it in the status epilepticus setting. It's relatively very well tolerated, very few drug-drug interaction. The only thing you have to remember is if you have a patient with end-stage renal disease, you might have to do some dose adjustment. Otherwise, excellent medication, very few side effects, and used extensively nowadays in our hospital.
Can I give them a hope? Can I give them people who are having status epilepticus, who are refractory, who are getting recurrent admissions? Can I give them a new hope that they also now have something new in the armamentarium, which can be helpful to them, which can also be orally available?
Exactly. That's the way I'll say it. One more drug in our armamentarium of drugs which you have, and it makes you more powerful as a doctor that you'll be able to help some of these patients when you use it IV.
A general practitioner who is managing a ER in his nursing home, or he's seeing a patient in his clinic, what is the message for him as far as lacosamide is concerned? Can he use it? Do you have to refer him, or he can use it in his clinic?
The general message is for a general practitioner, excellent drug. You can use it in your nursing home. It's IV, easy to administer. You really don't need much monitoring with this drug. Don't worry so much about the cardiac side effects. It causes some PR prolongation, but there are no instances of second or third degree AV block.
So therefore, in a setup where you are referring a patient, suppose you have a status epilepticus, you want to refer him to a higher center, and you have given him primary drugs, he's not getting response, so you can give him IV lacosamide and refer.
That's right, exactly. You gave him the first drug like lorazepam or diazepam, and then you give him IV lacosamide and then refer. That's fine.
Okay. And what about in the neurological setup, total extensive intensive care setup? Is this the drug of choice? Is it the last drug to be used before you give IV anesthesia?
Dr. Agarwal, in our hospital here in Cornell, we're using it a lot in the neuro ICU. The reason being it works very well. Like I said, the same points, very few drug-drug interaction, easy to administer, easy to load. So even in big centers, it's being used and we are using it. The idea is we want to avoid a patient going on IV anesthetic. So if we can stop the status epilepticus by using drugs like lacosamide or valproic acid or dilantin, that's the goal.
So in how many percentage still they will end up into IV anesthesia group of drugs?
About like this, like other studies said, at least about anywhere between 20 to 40 patients, 40% of patients will still go into a sort of a refractory status, and they'll need an IV anesthetic.
Okay, in this COVID era, we are getting encephalitis, we are getting meningitis. Are you using this drug in COVID encephalitis or COVID? Are we seeing status epilepticus in a situation like COVID?
We've had a few patients who have come into the hospital with status epilepticus and are COVID-19 positive. And yes, we have used IV lacosamide in this setting also.
So there is no contraindication in such situation. It doesn't cause CNS depressant?
It's not a CNS depressant. It doesn't cause, your patient will remain does not cause any respiratory depression. So in that's all advantages of this medication.
Can you share us some more experience about your handling COVID cases in as far as neurology is concerned?
Sure. Let me just bring you one thing which I'd like to share. Can you see my slide?
Yes.
So
you can directly go to the neurological complication because all this everybody knows.
So one thing I wanted to show, a few things which were there. When we had this COVID breaking out, basically what has happened in India, my father's telling me, outpatient neurology virtually came to a standstill. There was basically no outpatient neurology. There were two reasons. One was patients, we wanted to protect patients from coming to the hospitals because the hospital was full of COVID-19 patients. And the second thing which we found was patients themselves are very apprehensive of coming to a doctor, coming to a neurologist, whether the office practice is there in the hospital or outside the hospital. They just didn't want to step out of the house. They were so scared of getting the COVID-19 infection. So outpatient neurology, all our practices, they virtually came to a stop. Inpatient neurology also virtually came to a standstill. So leading up to this pandemic, we got orders to discharge all our patients. So we discharged all the patients in the epilepsy monitoring unit because the idea was that we are going to get such a surge of patients that we needed to keep the beds free for the COVID-19 patients. So the stroke unit, epilepsy monitoring unit, which are a big part of neurology inpatient services, were closed. The neurological ICU became incorporated into the medical ICU. So literally the entire neurology department became a part of the medicine department, you can say. There was extensive reorganization of the neurology services. So, we have a couple of services in the hospital. We have a consult service, which does consultations, neurology consultations. We have a stroke service. We all collapsed them and it just became one service. There were a couple of reasons why I do that. We wanted to reduce the risks of exposure to the staff. So let's assume you're going inside the patient's room to see the patient. Either the resident will go in or the consultant will go in. You'll not have an entire team of doctors going in, because if the entire team goes in and the patient is COVID-19 positive, all the people get quarantined and they all get exposed to the virus. So there's a lot of reorganization of the services. How do we protect the residents? How do we protect the doctors inside the hospital? Do we need one doctor going 4 times a day to look at the patient? Can he look at the patient only once? Can he use an iPad to look at the patient? All these things were thought about. Obviously, there was a redeployment of the neurologists. We all redeployed. Some of us were sent to the emergency department. A lot of us were sent to the inpatient medicine floor. Some of us were sent to the intensive care units. We had new protocols which came out. As you know, neurologists are famous or infamous for doing a very long examination. We check everything. Well, do we need to do that? We don't want to spend half an hour in the patient's room who has COVID because you risk getting exposed to it. So can you do a more restricted neurological examination? Can you do the examination remotely with the help of an iPad? There's a nurse inside the room and she is directing the patient to do what you are telling the patient to do. Can we do CT scan in place of MRI? The reason that came about was that once a patient uses a CAT scan or MRI and he or she is COVID positive, it takes 1 hour to wipe the machine clean because the machine has to be completely wiped clean. So protocols change. Do you need the imaging? If you don't need the imaging, if it's not going to change your management, don't do a CAT scan. Say, okay, fine, I don't need it right now. Just do an examination. So there's less testing. And then there was change in the stroke unit metrics. Like, for example, in stroke units, everybody talks about the door to needle time, how long it take to get the TPA into the patient. Now, we had a lot of problems. The patient is restricted. Getting the patient to the MRI is difficult because the entire staff has to wear the personal protective equipment, take the patient to the MRI, get the MRI done, then the MRI has to be cleaned out. So the stroke unit metrics change. Can we get the TPA into the patient within the golden hour, or it takes more time? We all, as doctors, learned new things like personal protective equipment. How do you put on a personal protective equipment? How do you put on a N95 mask? How do you put on your gloves? How do you put on the gown on top of you? How do you take it off? So there were all these videos which came out. We all had to take those videos and be certified. Before we went inside the unit, we had to demonstrate that to an instructor that we knew how to put it on, how to take it off. Then with COVID-19 neurology, Dr. Agarwal, a few things which I saw in my own hospital. We had patients with myasthenia gravis who were presenting with COVID-19 and an acute exacerbation of myasthenia. There's a question, how do you manage them? As we know, there was a concern that in COVID-19 patients, you should not give steroids. So now you have a patient with myasthenia coming in, you cannot give steroids. Should you give steroids? Can you give IVIG? Also, hydroxychloroquine, which was being used a lot for COVID-19 in the past, as you know, it's contraindicated in patients with myasthenia gravis. So how do you manage a patient with myasthenia gravis who also has COVID-19 infection? Very hard. Epilepsy patients, like you asked me, some of them are presenting with status. Some of them were COVID positive, some of them were COVID negative. How do we manage them? We did not want to keep them in the hospital too long because the hospital is full of COVID-19 patients. So if the patient is COVID negative, how do you manage him? How do you control the seizure and get him out quickly? We had 2 patients who presented with COVID-19 and had diplopia and vision problems. And this was reported kind of like a Guillain-Barré syndrome. We had 1 COVID-19 patient, I remember, was presented. She had dissection of the carotid artery because she had been coughing so violently with the COVID infection. Then acute stroke, we have seen a lot of new stroke coming in, and this thing has been now studied. What is the correlation? Does COVID-19 make people have more strokes? How do you best manage these patients? So a lot of these things which were coming out was how to do it. Last slide, which is also important, was how do you reorganize your labs in the hospital, neurology labs, when the COVID-19 pandemic is going on? Again, technicians are very worried of getting the infection. So you tell a technician, now you need to go into the patient's room. The patient is COVID-19. You wear all this mask, and you have to stay inside the room for 25 minutes to get the EEG done. You can understand there are a lot of concerns. So we kind of reorganize our services, less of testing. Does the patient need an EEG? If he doesn't need the EEG, can the EEG be very short EEG rather than a very long EEG? How does the technician put on the mask and take off the PPE? Can we use disposable electrodes? Once the technician comes back from the lab, how do you clean the entire machine? So a lot of these things were discussed about how to kind of manage the COVID-19. And my thoughts are, my experience has been that when I hope and pray COVID-19 does not hit as a surge in India, but Indian doctors, Indian hospitals will have to think in the same way, because it's very easy that you get exposed to COVID-19 patient and then you get your entire staff quarantined. So you really have to think a lot about reorganization of the neurology department, medicine department, cardiology department. How do you manage these patients who are COVID positive? How do you protect the patients who come to the hospital who are COVID negative and they don't want to get COVID while they're in the hospital? So a lot of these things went on. Obviously, I'll show you one slide which is there. This was a lot change in New York. As you can see, as for a city that never sleeps, the city is sleeping. The streets are empty, parks are empty. You see a squirrel there. There's no children playing, nothing. We have seen a lot of new signs which have come up. As you can see, we have what is called as contactless delivery, social distancing. Savannah Bhavan put up a whole sign about eating vegetarian food during the COVID-19 pandemic. All these signs are now there in New York. As you see them, they're all public signs about staying 6 feet apart, stay home, wear a mask. And really, there's been a big sort of a public sort of a learning curve, educating the public how to protect themselves. Last but not the least, there have been some good signs also. As you can see, these are signs outside my hospital. People have put up a whole poster saying they are very grateful to the medical staff. And it's been a challenging time, but it's been also a big learning curve.
So can I take a few more questions with that? And before that, I say is you said 30 minutes of neurological time. And we have a Singapore guidelines available. And Singapore says their official guidelines says if your contact time with the patient is less than 30 minutes, and if you are wearing personal protective equipment, then you are safe, even if the other person is COVID positive. Therefore, they say surgical time, make it less than 30 minutes. Your OPD times, make it less than 30 minutes. If you see 5 patients in 30 minutes, take a break. And your neurological examination should be as short as possible. So they define a significant contact as 30 minutes contact.
Right.
And the same thing is being done in New York, I feel. Now I
Yes,
come back to your experience with seizures as far as COVID is concerned. How many of them will get seizures? Now, if in a hospital in India, suppose I'm running a nursing home, I see a patient with seizure in the COVID era. Okay. Normally, I may spend a lot of time with him, try this medicine, try that medicine, try that medicine, may keep him in the hospital, try to stabilize him, try to arrange. Now I want him to be stabilized as early as possible because I want his stabilization time to be less. I don't want sister to be there with him. I don't want relations to be handling him. Do you think that IV lacosamide in such situation may be a game changer? That it may give a early stabilization?
it certainly can be used in that regard. Like you said, you want to stabilize the patient quickly. You give the IV diazepam or IV lorazepam, and then follow that up with IV lacosamide, shut the seizures down, and the job is done. So yes, it can certainly be used like that. Loading dose is pretty fast, anywhere between 100 to 400 milligrams.
So there are 3 more questions I have received. Lots of questions, but I've selected 3 of them. Is there any difference in the management of generalized versus partial status epilepticus?
Yes, I mean, as I teach the residents, when you have a patient with partial status epilepticus, you have time to control the status. Yes, it's a neurological emergency, but it is not as big as emergency when you have a generalized convulsive status epilepticus. So in a partial status epilepticus or a non-convulsive status epilepticus, I would say you should definitely try at least 2 or 3 IV medication, like you use IV dilantin, use IV lacosamide. You can even add IV levetiracetam. You can have 2 or 3 drugs added, and you try your best to control the seizures without resorting to an IV anesthetic.
Another thing you talked about burst suppression. What is the significance electrophysiologically? What should be the endpoint? How important is acid-base disturbance management in status epilepticus in contributing to drug levels in CNS and seizure control?
So I purposely did not say much about it, but like I said, once you are putting the patient on an IV anesthetic, you can't do a clinical exam anymore on that. So you don't know whether the seizures have responded or not. The patient might not be moving externally, but internally the brain is seizing. So you put the patient on an EEG monitor and you look. If the patient is still having seizures, what you're doing is you're trying to titrate up the propofol or the midazolam to what is called as burst suppression on EEG. That means on the EEG, either the EEG becomes completely flat, that's isoelectric EEG, or it's flat with a little burst of brain activity and then flat. And the idea is once you reach the stage of burst suppression, electrographic seizures in the brain have stopped. So that is thought to be the time where you say, I have controlled his or her status epilepticus. I reached burst suppression on the EEG. Now, you keep them in burst suppression for about 24 hours. So the EEG is running for 24 hours, they're in burst suppression. And after that, you start lowering the IV anesthetic down, lower the dose of the propofol to see what happens. 2 things might happen. They may not go back into status epilepticus, job is done. They might unfortunately go back into status epilepticus, and that's the term which was called super refractory status epilepticus. So you need to have EEG guidance to help you with the administration of the IV anesthetics.
What about pregnancy? Lacosamide versus pregnancy?
Dr. Agarwal, lacosamide is safe in pregnancy. I've used in a lot of my women with epilepsy, pregnant women with epilepsy. It's a category C drug, but very less risks of major congenital malformations. It's thought to be safer than other medicines like valproic acid.
What about hepatic failure, hepatic encephalopathy, deranged enzymes of the liver?
No, it doesn't have any hepatic metabolism. Only contraindication is renal insufficiency, end-stage renal disease, where you have to reduce.
Most of the people are asking one question. At least 100 of them have asked the same question. They want to compare lacosamide versus levetiracetam. How do we differentiate? When do we prefer one over the other? Because people have used a lot of levetiracetam. Now they want to know the difference between the 2.
Both are good drugs. IV levetiracetam has the advantage, again, like people have now got used to it. 1,000 milligrams IV, it can be used in status epilepticus. This is a new drug, as levetiracetam, equally good, equally effective. There's no head-to-head study between lacosamide and levetiracetam, but they're both equally good drugs, both have equally safe side effect profile. And so I will say that you should try it and see how you feel, how comfortable you feel. It's easy to administer, it's IV formulation, and you'll have, like you had said, Dr. Agarwal, another drug you have in your armamentarium to use when you're confronted with status epilepticus.
Do you feel that if I give him first levetiracetam and if it is not effective, I can try lacosamide?
You can either use it like second line, like you give IV levetiracetam first, and then if it did not work, you follow the IV lacosamide. You can even use IV lacosamide first. If it doesn't follow, you do IV levetiracetam. So that's how you treat status epilepticus. You do benzodiazepine first, and then one of these other drugs, either one or two of them.
And another thing is, a couple of people are asking about it, COVID encephalitis, 1, COVID Guillain-Barré syndrome, 2, and COVID meningitis. And 4th is presence of COVID in the CSF.
Right, so COVID encephalitis, I would say I've read a lot of EEGs on patients who have COVID-19. Just last week, I read a patient who's 96 years old with COVID-19 disease in the ICU. And most of the EEGs have shown basically a diffuse encephalopathy, diffuse theta delta slowing. So there's not really an encephalitis, it's an encephalopathy where they have a cerebral dysfunction because the brain is not working well. We still don't know whether COVID-19 is actually a neurotropic virus. No study has shown that it actually is a neurotropic virus and causes an encephalitis like Japanese encephalitis. It does cause an encephalopathy. And you might say the encephalopathy is also because they have multi-organ dysfunction. Their kidneys are not working, the livers are not working, so the brain is not working. We have certainly seen a few patients with, like I showed you one with diplopia. There have been reports of Guillain-Barré syndrome with COVID-19, few reports, case reports. So yes, that has definitely been there. And especially with stroke.
Topiramate in status epilepticus?
Topiramate, very good drug, broad spectrum anticonvulsant. The only problem is there is no IV formulation of topiramate. It's only oral. So how are you going to get inside the patient when the patient is actively seizing?
Can you describe the patient who have a large vessel stroke with COVID?
The patient with large vessel stroke with COVID is a patient who's coming in with a stroke of the right MCA. And nowadays, every patient who's coming to the hospital is being checked for COVID. There's no patient who's admitting to the hospital who's not checked for COVID. In fact, now, the other day, I got an email from the hospital. We feel that COVID is going to remain with us for some length of time. So now they are kind of reorganizing the hospital again. Part of the hospital is going to be for COVID positive patients. Part of the hospital is going to be for COVID negative patient. Now, if a patient with stroke comes in and he's COVID negative, he goes to the part of the hospital which is for COVID negative patient. Every doctor, every nurse who goes in to see that patient has to be COVID negative also. So the doctor and nurse also have their testing done to make sure they're COVID negative.
So do you feel that all patients who are epileptic patients in a general practice should we get their antibody test done to find out their status or get their COVID test done? Or if they are coming with, even if they say my seizure is increasing, we go ahead with the COVID test?
I think
even if they have no fever.
No, I think Dr. Agarwal, that would be very hard logistically, but to protect, nowadays I was telling my father also, you should think about every patient who comes to see you in your office or in your hospital as potentially COVID positive, because you need to protect yourself, because the patient comes in and your staff all gets exposed to it, then you're in big problem. So every patient who comes in should be wearing a mask. Every patient should be wearing a glove. So now when we have opened the hospital again, before the patient comes in to see me, he or she will get a mask and gloves from the security guard. We have made the waiting room such a way that only like 5 or 6 patients are separated by 6 feet apart. And we have now divided the OPD time for the doctors. So like I have a slot from like maybe 8 to 10. That time only my patients are going to be in the waiting room. Then from 10 to 12, some other doctor will be there. So we have opened up the OPDs for a longer period of time over the day, but small slots, because we don't want patients to be clustered in the waiting room. On a normal day to enter the elevator, there are 20 people waiting to enter the elevator. We can't have that. So you really have to reorganize the hospital so that the patients are protected and the doctors.
Do you think that in New York, number of cases are going down?
The only silver lining is the number of new patients coming to the emergency department getting admitted is declining significantly. But we
That
still,
means your growth rate is reducing. Number of new
yes,
cases today
yes,
versus tomorrow,
yes.
yesterday.
But unfortunately, Dr. Agarwal, we still have about, I would say, New York City itself, about 2,000 plus patients who are in ICUs, all with COVID, all of them on ventilators. Once they go on a ventilator, they are staying on the ventilator for about 2 or 3 weeks. And unfortunately, these are the people who are dying. So every day when the death toll comes out, it's still ranging between,
So the
at one
death
time it
will
was
decide.
800 a day.
So death will continue for next 14 days because time to death is 14
Right,
days.
right,
And these are the cases. So
exactly,
death rate we don't even bother about because death
right.
will occur. If you have
That will
serious
occur.
patients, 15% of them will die. That we all
Exactly,
know.
you're right, you're
So
right.
if the new cases are coming less, and there is a study which I saw that 20 to 25% of New York population at random, they have tested antibodies, they are positive.
Right.
If that's so, and if the number of cases are going down, do we feel that the herd immunity level for COVID is 20 to 25% or 30% and not 66% as it has been said? Because
That's
what
a
I'm
very
saying
good.
is in whichever city we are seeing, Korea, approximately 20% of the population has got infected. And if in India also 20% of population, say in Mumbai, in Delhi, if 20% of the population gets infected, you probably your peaks starts reducing and you start getting less cases.
I
Otherwise,
think
what
that's
is the reason of getting less cases in New York?
the thinking is like exactly like you said, that probably a lot of people have got it. Either they had mild infection, they remained asymptomatic, or they never came to the hospital. But when they're checking the public, like you said, a significant number of them antibody positive. So if you have COVID antibody positive, the thinking is that you have some amount of immunity. We don't know whether it's lifelong or not, but the thinking is that likely reinfection, if it occurs, will be mild. So they're talking about an immunity passport also. But you're right, probably that's what is happening in New York. It's kind of burnt out here now.
And what about other states in US?
In US, Dr. Agarwal, a lot of the country has already opened. Big parts of Texas, Georgia, they are already opening. So
Before I take that, there's one more question. Can we combine valproate and topomac?
well, you can certainly, IV valproate is available. Topiramate is not IV. The only other concern I'll have is valproate causes increase in ammonia levels, and so does topiramate. So when you give both valproate and topiramate, both working to the liver, hepatic metabolism, you might have a hyperammonic encephalopathy. So I would usually not combine, valproate with topiramate for that
Okay, what
reason.
about loss of taste and loss of smell as a presentation in COVID in New York?
We saw it a lot. Not initially, we're not sure, but then I think, like every respiratory virus will cause loss of sense of smell. Now, whether that's special to COVID or not, it's not clear. But we have seen a lot of dermatological manifestations with COVID. So
And what
now,
about walking dead patients? Walking dead patient, otherwise all right, neurologically conscious, and otherwise we see hypoxia, silent hypoxia, oxygen level 60, 70, and talking. Otherwise, neurologically no symptoms, but
right.
very severe hypoxia.
Exactly. There seem to be patients who manage hypoxia pretty well. They'll have oxygen saturations in the 80s, even lower than that, and seem to be asymptomatic. Checks X-ray will show bilateral infiltrates, but they seem to be doing well without being on a ventilator.
And what about inflammatory? We call them as, instead of saying them, we say this is inflammatory and thromboinflammatory disease. It causes lots of thrombosis, D-dimer is positive, and all those cases should be on TPA, or they should be given on heparin. So do you feel that such cases, because if they are a thrombotic disorder, they may end up into seizure?
Right. So the microangiopathy and the microthrombosis has been looked at very closely. And now we have a protocol of putting these patients on prophylaxis for DVT, prophylaxis for pulmonary embolism, all those things. Because yes, that has caused a lot of mortality. And that's also thinking maybe that's the reason for the strokes also.
So are you also giving hydroxychloroquine and azithromycin combination, or only hydroxychloroquine?
No, Dr. Agarwal, we have stopped the hydroxychloroquine because the results were not encouraging. So now we are doing the trial with the remdesivir.
And what is the response of remdesivir?
It seems to shorten the stay, the ICU sort of stay from like 15 days to maybe 9 days. So it seems to have some positive response in critically ill COVID-19 patients.
So
Reduces the viremia.
lacosamide has no interaction even with the anti-COVID drugs.
No, lacosamide should not have any interaction with any of these drugs. Goes through the kidneys. Most of the other drugs, by and large, go to the liver.
So nowadays, you people are saying is, how are you preventing yourself, except for 6 feet of distancing, social distancing, and gloving?
Well, I wear the mask. I got my antibodies checked. I was borderline positive, and we're just making sure that not to fall sick in the first place.
And when you say borderline positive, means IgG or IgM?
It was IgG.
That means you have already cured.
Well, I mean, but I was not like frankly positive. I was making good antibodies. I can give, like, it was kind of plus minus. But one thing which I'll say is it's not the COVID-19 disease itself, the management, which is a problem. It's the surge of patients which come. They just come like a surge. It hits you like a tsunami. That time you just get overwhelmed, and then it kind of just goes away. So that's what happened. We got a surge, and now, in fact, the whole hospital is practically empty because there are no patients there.
So, dear colleague, here comes the end to this seminar. You have seen, he started with epilepsy, ended up with COVID. I will start with COVID and end up with the epilepsy. We know that COVID is going to stay. We know you have to live with Corona. You have to live with COVID. You have to make him a friend. You have to take precautions so that he lives with you, yet he does not damage you, does not enter your body. You need to increase your immunity so that even if he goes inside, he is only taking a friendship with you for 14 days and does not damage your lungs, does not damage your heart, does not damage your brain. Otherwise, it will cause a proteon manifestation. You take care. When you know that you have to live with COVID, so is true with epilepsy. Epilepsy, you have to live with it. If you have to live with it, you have to live with it. You have to make friendship with your epilepsy. You need to know everything about epilepsy, and you need to control. You need to know what can precipitate epilepsy, and now you need to know that it is possible. You know, Bhagavad Gita, Krishna said, "Whenever, don't worry, I'm there." He says. So similarly, new drugs, and now a new drug called lacosamide says, "I am there. Don't worry. If everything fails, try me also." Before you go for a IV anesthetic group of drugs. Thank you, Nitin, to be here with us. And it was wonderful having you with us. And I'll pay my regards to your dad. I'll also speak to him. And I'm very sure that all our listeners, they got benefited with this seminar. And I thank all of you to be here with us. The link is available. We will send it to you, to everybody. We'll send it to you, Nitin. And we will also send this link to all the doctors in the country. Thank you very much.
Thank you, Dr. Agarwal. Thank you.